Morning, everybody. So we would like to demonstrate two different teledermatology models used for obtaining tertiary care advice for nail disorders. Before we start, I've got no conflicts of interest to declare. So disorders of the nails are challenging, and there are a few centres that provide a specialist nail service for patients. Bristol has provided a teledermatology nail service since 2004, and we refer to this as a many-to-one service because many clinicians have sought Dr. DeBerker's expertise via email for their patients with nail disorders. The European Nail Society has also provided a teledermatology forum for the same period, and this is called eNail. And in contrast to the Bristol service, many nail specialists give advice on one clinical case. So we refer to this as a one-to-many service. The aims of this talk are to illustrate these specialist services and consider their advantages and limitations, but also in analysing the case mix from the Bristol service, we've been able to identify challenging areas in the diagnosis and management of nail disorders, and this could be useful for defining a curriculum for a specialist education in dermatology. So we've illustrated this talk with cases where consent to show the photographs to medical staff is explicit or implicit. No patient identities are involved and are rarely communicated in the referrals. So we'll firstly look at the Bristol service. We reviewed 552 referral records from 2004 to 2015, and the following clinical details and other details were collated into a spreadsheet. The geographical location and healthcare setting was noted. The number and quality of clinical photographs were graded from too poor for interpretation, grade 1, to excellent, grade 5, using predetermined descriptors of photographic quality. Affected nails as listed in the digit type column were counted, and the nature of the clinical question and response given were noted in terms of diagnosis, investigation, management, or any combination of these. The clinical problem was then broadly categorised into 8 main categories, as demonstrated in the right-hand column: inflammatory disorders, mechanical and traumatic disorders, tumours, fungal or other infective pathology, pigmented change, miscellaneous and unclassifiable nail disorders. This allowed us to identify and quantify those pathologies that cause most uncertainty. So moving on to our results. Where the country of origin was specified, 83% of these referrals, which represented 455 referrals, came from the UK. The remaining 17% were from Europe, Australasia, the United Arab Emirates, South Africa, and the United States of America. 90% were from hospital clinicians, 9% were from primary care, and 1%, which represented 8 referrals, were from patients themselves. A modal number of 2.9 images with a range of 3 to 12 photographs were received, and of 469 image sets, the mean quality score was 4.5 out of 5. 72% of referrals had no provisional diagnosis at the time that they were referred. So, unsurprisingly, the most common question related to the diagnosis of the nail disorder in 77% of cases. 61% wanted help with the investigation of the nail disorder, and 48% of referrals asked for advice with regards to management. This table demonstrates the categories that we previously described, and we'll move on to talk about each one in turn, but you can see that the most common questions were related to inflammation of the nails or inflammatory disorders, accounting for 21% of referrals, closely followed by mechanical and traumatic pathology. So in terms of inflammatory nail disorders, it included often lichen planus, psoriasis, eczema, and chronic paronychia. A few common examples that came in as part of this category. So, is this lichen planus? Should I biopsy it, and how should I treat it? Are these changes nail psoriasis? What treatment should I give? And could this be contact dermatitis? In terms of mechanical and traumatic pathology, which accounted for 19% of referrals and included subungual hematoma, common questions were cases such as these. So could this be fungal and resistant to terbinafine? Why are these toddlers' toenails this shape? Some red toenails. Dr. DeBerker asked what colour this gentleman's socks were. And the final one, how do I manage a pincer nail, which is also quite a common question. 16% of inquiries were for nail tumours and 7% for pigmentary change, and all of these were variants of melanonychia. Common questions. How should I manage this longitudinal melanonychia? And this was a common question in both adults and children. Could this nail defect be due to a tumour, and how do I investigate it? And how should I manage this Bowen's disease of the nail? 6% of referrals related to fungal pathology, and 5% were due to other infections. Common questions again, so is this fungus, and how should I manage a fungal nail infection in a child? How should I manage this Pseudomonas nail infection? And could this white streak in an immunocompromised patient be due to a fungal infection? 15% of inquiries we classified as miscellaneous, and this included 19 cases of yellow nail syndrome, as well as some severe keloid scarring to the nails. And this picture here of nail changes in a renal transplant patient due to hyperparathyroidism. So I'll now move on to talk briefly about the European Nail Society, which has been established for almost 20 years. Members are able to submit clinical cases to a panel of experts, and for this reason we refer to it as a one-to-many service. Here is an example of a case taken from the European Nail Society. So this 14-year-old boy bites his nails aggressively and suffers secondary ingrowing of the natural nail fold. 2 questions. How would you manage this ingrowing? And what's your general approach to nail biting? Here are some of the responses given. I've highlighted some of the key recommendations, and these are responses taken from around Europe where English isn't necessarily the first language. I'll just give you a minute to read some of those. Here are some more responses. As you can see, the suggestions to manage ingrowing include protecting the nail, topical antibiotics and soaks, and cutting the sides of the nail, and steroids. In terms of reducing nail biting, covering the nails, psychological support, distraction tactics, including chewing gum and bribery, were all suggested. This demonstrates how multiple teledermatology responses from many specialists commenting on the same case can yield diverse opinions. Through illustrating these 2 different teledermatology models, it's possible to appreciate some of the benefits and limitations of each. Both rely on expertise and are dependent not only on clinical image quality, but also specific patient details and a clear clinical question. Both may be open to bias and weighted perspectives unless muted corroboration is achieved in a one-to-many service. In some ways, this last model of sending a standardised question to many experts mimics a process used in radiology and histopathology, which is a form of external quality assessment. When a particular question is asked to many specialists, the opinion offered by the individual expert should fall within a calculated closeness of fit with the consensus of the whole group. We know that forms of EQA are used by MoleMap in New Zealand and in the Oxford Teledermatology Service, but we'd be interested to hear examples of this being undertaken as an integrated part of established teledermatology services. So in summary, we have illustrated 2 nail teledermatology specialist advice services and the nature of nail diseases requiring specialist contribution. The recurring themes enable us to outline a potential educational syllabus for dermatologists on nail disorders. Similar services could be run in other specialist areas of dermatology to provide clinical guidance and help to define a syllabus for postgraduate education in that specialism. And possible topics for national teledermatology advice services include the following. Thank you for listening, and we welcome any questions.